The next speaker is a quite eminent in the field of infection control. His topic, he has made some mild changes to the topic. It will be called as Insights into Instrument Disinfection. It's my proud privilege to welcome Dr. Vikas Manchanda. He's a MD in microbiology and MBA as additional qualification. He's a professor in the Department of Microbiology as well as Infection Control Officer in the Maulana Azad Medical College and Associated Hospitals, New Delhi. He has been holding various positions in various associations, but most importantly, he is the chair of the technical committee of NABH, as well as in charge of State Laboratory for National Viral Hepatitis Control Program in Delhi. Without any other, there's a long list of, he's a quite eminent personality in the field of infection control and microbiology. So I'll request Dr. Vikas Manchanda to start with your presentation, sir.
Very good afternoon. Thank you for your kind introduction. I am hearing the session and it's really going wonderfully. And I think it is what is being asked for from this particular session. I can assure you that it is very, very important aspect of the whole instrument disinfection. So we must again see it carefully. So this is the outline of my presentation. What is an ideal disinfectant? We will be talking of it. Spalding classification has already been introduced, just to go through it. Then factors affecting efficacy of the disinfection, available disinfectants, cleaning good practices, integrity testing and efficacy testing, and then the challenges what we are having in the near future. So 2008 was the year when the CDC released the guidelines for disinfection and sterilization. And this was probably the first document which was having a very much in detail and systematic manner how we can go about it. Ideal disinfectant was defined by the CDC in the same document, and it is like a long wish list, starting from that has to be broad spectrum, fast acting, not affected by environmental factors and so on. We are still far from an ideal disinfectant. Spalding classification is the backbone of disinfection process if we want to understand and which kind of disinfection or what level of disinfection has to be done to what kind of instrument or equipment. That is easily based on it once you understand this. So we have the non-critical, semi-critical and critical items, out of which critical items straight away go out of the disinfection ambit as a final consumed product. They do require initial disinfection, but as a final consumed product, they have to be sterilized, whereas semi-critical item and the non-critical item directly get under the ambit of disinfection process and ready to use thereafter. So when we think of the disinfection process, there are many factors which influence disinfection, starting from what kind of pathogen we want to get rid of. It may be simple HIV virus, which is very, very fragile, to a Prions specialized protein, which are very, very difficult to get rid of. As we go on in the presentation, we will see. Bioburden in terms of the quantity of the quantum of contamination which is there. Biofilm accumulation based on the poor or suboptimal disinfection practices and accumulation of the more resistant bacterial flora. Cleaning, I think it has already been very well dealt with it. So I will be just looking with 4 or 5 slides. Then we have the protein diameter of the instrument and the flow by which you are cleaning, that all affects the whole of the disinfection process. So this is a matrix of all the bugs which we deal in and out in today's hospital practice. So starting from the enveloped viruses, which is very much fragile, the envelope goes off as they are lipid containing envelopes, to the more resistant Prions disease, we have the increased level of disinfection which is required, which is known as high level disinfection. So most of this flora which is there on the instruments come either from the endogenous, which is majority of the infections being caused by almost 40 to 60%, as well as exogenous flora where medical devices come into play. So almost 20 to 40% of the infections are occurring due to these inappropriate disinfection practices. So this is just to understand what is low level, intermediate, high level disinfection, sterilization. What we want is security assurance level, or SAL, of 1 million uh, bacterial, one viable cell in 1 million bacteria which is being initially processed with. So that is the tolerance limit of the sterilization, whereas it's almost 1000 times lower when we talk of the low disinfection. High disinfection is very, very close to the sterilization. So it is like this. So these are the common disinfectants which you all know, which are available in the market, and every single day there is one company launching a product or a disinfectant with some new name or new compound. So we will be going into it, how we should carefully look into those proposals which come into the hospital for the new disinfectants. So this is about the burden and the biofilm. We have three different types of biofilms. One are the traditional hydrated biofilm, which generally form immediately after use or during the surgery and all. But if being cleaned off, it can be easily cleaned off from the equipment. Then we have the dry surface biofilm and the build-up biofilms, which are much harder to remove and become the source of infections if we do not deal with it during our disinfection process. So this is just to tell you the difference between the hydrated and the cyclical buildup. So hydrated is very much fragile and it can go off with the cleaning process and brushing and all. Whereas the cyclic buildup, which is there, which is generally happening on the endoscopes and those kind of equipment, this is the one which is really hardy and is difficult to get rid of. So we have to have the process in the place where we can minimize buildup of these kind of biofilms on the instruments and the scopes. This is just the conventional comparison between the glutaraldehyde and the OPA, which are being used commonly as a common disinfectants. Glutaraldehyde, one of the most common disinfectant being used after sodium hypochlorite. OPA has come up, but it has its own major limitation, one being the 20-degree requirement of the solution for the inactivation. And then second is the anaphylactic reactions in the patients where you are using it, the devices are being used repeatedly. Apart from it, staining and all also are having problems. So the cost makes the glutaraldehyde more lucrative option than the OPA in the Indian setting. Then depending on the concentration of glutaraldehyde, we have to see what should be the contact time or the exposure condition which are there. Because when you are into the market, you may have different composition of glutaraldehyde with and without alcohols and phenols which are available in the market. So the label, what says, is important when you are using glutaraldehyde in your clinical practice. Third, or the more upcoming reagent which is there is the hydrogen peroxide, which has a lot of advantages in terms of it is close to so-called ideal disinfectant in terms of no activation required, no environmental disposal issues, no odor, and so on. But major disadvantage is the compatibility specifically for certain specific metallic coatings which are there, and it is a bit toxic if it is being exposed to the eye. There are ready-made hydrogen peroxides which are available, or there are various peroxygen devices which are available where you can prepare your ozonated water or superoxide water or activated waters in your own facility. But there are just certain challenges which you need to keep in mind when you are deploying such systems. How you're going to check for that, whether the quality of the product which is being promised is being delivered. So it is not going to be one time, it has to be ongoing monitoring process. So you need to establish that. Second is the stability of the generated disinfectant, how you are going to keep it, how long you can use, the storage conditions, and for what purpose you want to use it. And the last of the list is the Paracetic Acid, which is also one of the very good disinfectant, although not very popular in Indian market. Then is the decontamination cycle, which is very, very important to understand the disinfection process for any instrument. I think cleaning has already been talked of. This is what is the scenario once this procedure is done into the operation theater. And we really need to look into that the disinfection starts here. So if you are mismanaging, not managing the things at the bedside level, it becomes harder for the whole disinfection process to continue. The rusting, the joints, all these are part of inappropriate upkeep of instruments starting from the bedside to the cleaning. So that has to be looked into. Depending on the type of equipment or scope, you can have the automated cleaning systems which can start from the bedside to the manual cleaning at the bedside, or initial rinsing, or what is known as primary rinsing, which can be done, and then the instruments can be put up for washing. So what is important here is do not let the instruments dry up, because once dried, all the organic matter and the blood stains are going to become harder to remove. So if nothing is possible, at least we can put a wet mop over the instrument so that it can be delayed for the drying purpose. Although there are certain commercial systems which are available, starting from transparent gel to a foam to a liquid cleaning solutions, which are available in the market to delay the drying and keep it. Similarly, when you are looking for the endoscopes, I will be just touching upon it because there is a full session on the endoscopes. It should not be stored into the transport box. They need to be hanging, and when you are putting it in the drying, it has to have a cabinet which has a HEPA filter, because the air which is going to enter the lumen, which is not sterile, is going to create problems. Then the other things which are coming up in the market now are the ultrasound transducers and various scopes which are there for catheterization and other procedures. So here the recommendation is that you, as a first step, need to do the low level disinfection, followed by some kind of covering, be it a single use condom sheet or the transducer sheets which are available in the market. Both can be used, and it has been found that the condom sheets are much better in protection and use than the transducer sheets. Blood contamination of probes generally is infrequent, so high level disinfection of probe is rarely warranted when you are using these condoms or the transducer sheets. But if there is a breach, you need to subject the probe to high level disinfection. And here the important point to remember is that when you are using condoms or the transducer sheets, once you remove it, please check these sheets and the condom for the integrity after procedure, because if there is a breach in the integrity, then probably you have to go for the high level disinfection. Visual inspection of devices is as important as cleaning and all, because after cleaning, you see on the right panel, you have certain bone chips which are being left. So that is again very, very important. There are certain cleaning kits which are available. Whatever disinfectant you use, whatever automated washers, disinfectors you are using, you need to be aware of it. What kind of cleaning soil test kits are available to check for the efficacy of these. So they are very much available in the market. Soil detection kits. The classical example is for protein detection or hemoglobin detection. We have the MinHygrometer kit, which is available in the market. You can also use, like in sterilization, there are certain strips which are available, which can be put into the washers and can help you in understanding your whole efficiency of the washer system which are being used. But please remember, all these systems are ensuring the process, but will not ensure whether the device is clean or not. So apart from it, integrity testing has to be done. Develop a checklist. What all parts you want to see in each and every instrument which you are reusing, and before packing and doing the sterilization, that kind of checklist for integrity needs to be done. So the example here which has been given here is the scissors cutting potential being checked, which is done by the TheraBand. depending on the size of the scissor, red or yellow test material is being used. So what are new challenges? I have talked of that every new day there is a person who is entering into your office saying, I have a new product or disinfectant is available, please use it. Do not jump the wagon. Ask yourself first, do you really need it? So there are certain questions which should come in your mind when you are thinking of to introduce new disinfectant into your system. The efficacy, so you must have the Environment Protection Agency a clearance certificate for safety and efficacy and intended use, for which it has been approved of. Instrument compatibility, which you want to use, toxicity, ready to use, or it is going to be dilute, because the disinfectants where dilution is required, errors are being done by the staff and it may not give you appropriate dilution. Storage stability, whether the efficacy testing is possible in your setting if you introduce into the system. Training of the staff, exposure management, toxicity, as we have discussed, the cost and the environment review. These are a few of the points which you need to keep in mind. Also, do not just jump into testing every disinfectant into your microbiology lab by one odd bacteria or one odd fungus. There is a defined guidelines on what we mean by sporicidal, fungicidal, bactericidal and on, and special bacterial strains are there to establish the potency of the efficacy of the disinfectant. So try to follow the rules as they are laid on. When you're using the automated washers, their regular cleaning is very, very important. Weekly minimum, preferably daily, that needs to be done. To prevent the transmissions, we have various scopes and other devices which are available in the market, but it has been seen mainly the culprit are the GI endoscopes and the bronchoscopes, which are the major burden and are being translated into infection with the patient. So more focus towards those scopes needs to be done. So for reprocessing of scopes, majorly we have the manual high-level disinfection or use of the automated systems or disposable sheets as we talk of. UVC chambers are now available in the market, but the efficacy is still not proven and may be taken it from the manufacturer instruction if they allow it to do that. There are special instruments where all those things which I have just talked on the top may not help. So like tonometer tip, it requires the 5000 ppm chlorine or 70% ethyl alcohol, which may be required. There is new technology of hydrogen peroxide mist system, which is available. And similarly for the cautery systems, infrared coagulation, again, because very, very delicate tip is there, only bleach is the one for 2 minutes, which is required. Next challenge is of the prions, which is now coming up and in slowly creeping into the population. So we need to address that. Normal autoclaving is not going to help. They have special conditions which needs to be filled in. And last but not the least, we are now coming up with the devices which are nothing but the combination products. Combination products here means you have specialized beads which are being medicated for certain cancers and tumors. Beads are being used, brought back to CSSD, reprocessed, and then goes to pharmacy. The drug is being eluted on it and given to the patient again. So in coming time, you will be going to see these kind of things into the market. So you have to gear up with the SOPs for these products very soon. And with that, thank you very much.
Thanks a lot, Dr. Vikas Manchanda, for your time.